Hello and welcome to the Armor Men's Health Show. This is Dr. Mystery, your host, board-certified urologist and founder of NAU Urology Specialists, the bespoke urology practice in Austin.
Oh, a little callback from a previous guest.
I'm just making up words up now. I'm joined, as always, by Donna Lee. She really makes the show. She's our business development manager. She has been our practice manager and an integral part of our practice's story for how many years now?
7 years,
7
Dr.
years.
Mystery.
She gets a sperm pin for every year she's been with us. She's got
right.
more sperm on her lapel than she
I did in
high
college.
school.
That's right. I thought it was college. Is it
High school? Did you go to college? I don't even know.
I don't know.
All right.
Anyway.
Well, how do people get a hold of us, Donna?
You call us right away at 512-238-0762. You can also visit our super cute little website and see our shining little faces there. It's armormenshealth.com. You can submit your questions that we will answer anonymously to that website, armormenshealth.com. And remember that we're podcastable when you get your car, put on your favorite podcast site like Spotify, and we can be there right there for you.
So I love surgeons.
I know you do.
And I feel like the urologist's soulmate is the butt surgeon.
Perhaps.
And we have the original ass man himself,
That's right.
Dr. Thiru Lakshman.
He's like, no.
Dr. Lakshman, thank you so much for joining us today.
Thank you for having me.
You are a member of Texas Colon Rectal Specialists?
That is
and
correct.
How long have you been in the Austin area?
I've been in Austin in practice for 14 years.
Tell us about your education. Where did you go to college and medical school?
Sure. I went to college at the University of Pennsylvania in Philadelphia, and then I went to medical school at the University of Kentucky. And then
They have medical schools in Kentucky?
Yeah, it's amazing. I know. Well,
Did they give you safety knives and safety scissors
you'd be
there?
surprised. You'd be surprised. Yeah, that's right. Generally, we're lucky if at the end of a clinic day you find one set of teeth amongst all the patients together. Yeah.
All right.
No, it was great. It was very nice. Yeah, my family actually is in the Tennessee, Kentucky area, so I went back home for medical school, and then I went back to Philadelphia for many years. I did all my general surgery training up there at Jefferson University Medical College there, and then down to Florida at the Cleveland Clinic for my colorectal fellowship.
And when you were coming up, robotics as a component of colorectal surgery wasn't necessarily kind of the standard. So you really had to learn a lot of that after training while you were in practice. What benefits does robotic and laparoscopic and minimally invasive surgery have for your field?
Yeah, I think it's huge. I think it's a huge benefit. And you're right. When I first started, like in my surgery training, there was laparoscopy, which is sort of the minimally invasive technique that's sort of been around for a long time, for the past 20 years or so, maybe even longer, 30 years. Robotics was just getting started. And it's really, as you know, you do robotic surgery as well, too. It's really the sort of latest evolution of minimally invasive surgery. Colorectal surgery specifically really is well suited to minimally invasive surgery because a lot of the things we do, they already started doing laparoscopically many years ago, and it was a really natural evolution to do it robotically.
Now, not all colorectal surgeons are able to do this. Most urologists that are going to remove prostates do it robotically. But there are still, a good number of open colorectal surgeons.
Absolutely. Actually, we just were looking at this for another talk I was doing. The national rate of open colorectal surgery is still around 40%, 40 to 45%.
Which is fascinating because there's only 2% of prostates are removed
That's
open
it,
nowadays.
2%.
Yeah,
No kidding.
98% are going to be done open, robotically.
The rate of increase it's increasing steadily for sure. And what we're seeing is with robotics coming out, that the people that are adopting minimally invasive surgery are the number of colorectal surgeons is increasing significantly, but they're actually skipping laparoscopy and going straight to robotics as the modality because I think it's easier to learn. It's a little bit more intuitive, and so it's almost like the benefits of robotic surgery is it's like you're doing open surgery inside the belly.
Inside the belly,
That's right,
and it can be very intuitive.
For sure.
Now, in our field, we're seeing technological advancements. We're treating a lot more conditions that we were treating with medicines now with surgical interventions. What about your field? What are some of the technological advances that you've seen or medical advances you're seeing or just kind of evolution of your practice?
Yeah, in colorectal surgery, so I think the first thing obviously is minimally invasive surgical advancements, like robotics. That's really making surgeries that were technically very difficult and that were done with big, huge open surgeries now we can do with, 5, centimeter-sized incisions, which all the benefits of that, right? So less pain, better cosmesis, less time in the hospital. So I think that technological advancement is there. Within robotics itself, there's new technological advancements now. When I do a surgery on the robotic system, I'm able to look at blood flow in real time.
That's really a big improvement. Now we know that the anastomosis, because you not only have to remove the tumor, but you got to put the colon back together. together.
That's right.
And that putting it back together can be real dangerous if it leaks, because now the person goes for another surgery.
That's exactly right.
But now you can evaluate that blood flow in real
For sure,
time.
yeah. We used to be able to, you can do it, and there's other ways you do it. We can actually do what's called a leak test. It's sort of like how you would look for a leak in a tire by submerging it in water and insufflating it with air, and we look for bubbles. We can still do that. But now by these added technologies of, it's amazing. They basically inject something through the IV, and 60 seconds later, you can see all of the blood vessels light up a fluorescent green color. You just toggle a switch when you're sitting at the robotic console, and you can see what's getting blood supply and what's not. And then so, the three main things we're looking at is we're looking at blood flow, and we're looking at the tension, and then we're looking at the anastomosis itself, the connection between the two pieces of bowel that we hook back together. And robotically, with these technological advancements, we can see the blood flow really in real time and look at it too.
So one day you got up and you were like, I could be a heart surgeon, I could be a urologist if I studied hard enough. But instead you were like, I'm going to spend my entire life in the colon where there's nothing but poop.
Yeah. It's funny because patients, and it's invariably when I have them like on the table, ass up, and I'm doing an exam on them, and they say, I just can't understand why you would decide to do this, choose this as a career.
I hear it all the time. When I'm sitting on the stool and examining their testicles, they're like, why? Yeah. Why would you do this?
We know why you.
Well, some of us have a thing.
Right. The funny thing is that I'm there doing it, and I'm like, well, if I wasn't here doing this, who would be doing it? Somebody's got to do it.
Somebody's got to do it.
My pat answer, somebody's got to do it, right?
Somebody's got to be here.
No, I think for me it was a very varied specialty in the sense that I could do lots of different things. When I was in medical school, and then I knew in medical school I wanted to do surgery, some type of surgery. I thought about neurosurgery, and I realized, I wasn't smart enough.
And you're way too funny. And you would have been a sore thumb in that boring university.
I would see those neurosurgeons, the residents, and by the end of their residency, their souls were so crushed and so deflated. They had no.
And they aged so poorly.
Their humanity was gone out of all of them. I said, right. I don't want to be like that. And I noticed the colorectal guys were like, they dressed nicely. They were nice. They were friendly. They seemed less stressed, But in
like a dermatologist.
Yeah, I wish.
They're the dermatologist of surgery.
That's right. Yeah. But then when I knew I wanted to do surgery, and I looked into, and I decided on general surgery, and colorectal was the best fit for me because I could do small, minimally invasive procedures. I could do colonoscopies, and then I can do big surgeries. I have a particular interest in cancer and colorectal cancer, and so I can focus on that. So.
And you do a lot of work to get people to get their screening colonoscopies.
Absolutely.
Colon cancer being one of the most preventable diseases. Why is it preventable because of colonoscopy?
Yeah, it's the third most commonly diagnosed cancer in the United States. Each year about...
Prostate's number one. We're number one.
Good for you.
We're number one.
We're shooting for it. We're shooting for number one. It's very prevalent, and I think now we're seeing more and more people get diagnosed because I think there's more screenings, but also I think there's a lot of environmental factors which we
absolutely
haven't gotten.
Absolutely. Diet.
Yeah, absolutely.
Environmental carcinogens.
And I think there's particularly that.
mRNA vaccines.
I think.
Oh, there it is.
We're going down that road.
Well, we have an audience.
I didn't know this was that kind of podcast.
We have an audience. We have an audience.
Yeah.
We have an audience.
You're just tailoring to the demographic. I see. Nice. But I think it's going to come out that there's going to be some particular environmental factors because I'm seeing it used to be in the first half of my career, it was all people over the age of 60, 65. Now it's the majority, if not half of them, are under the age.
Really?
Oh, yeah. Yeah. I see 25-year-olds, 28-year-olds, 35-year-olds with really aggressive colon and rectal cancer.
And these people have financial disincentives to get colonoscopies because they have high deductible health plans. They have, commercial insurance. They may not be insured.
That's right.
Unlike our Medicare population, where it's easy to kind of force them to go through it.
So and it's shifting.
That's worrisome.
It is worrisome, and it's shifting, right? Because I think they're seeing from population studies that it's younger people are getting it. So now the screening age went from 50 to 45, and there's talk even that it may get lowered to 40 actually, because they're seeing, just like I was saying, we're seeing younger and younger people with it. But the reason it's so important is because at the colonoscopy, if you find a polyp, you really heading it off of the pass, right? The progression to a colon cancer is you start off as a polyp. The polyp slowly grows over months to even years. And then not every polyp becomes a cancer, but every cancer, 99% of all colon or rectal cancers
started as a polyp.
So if you can catch it a polyp, you've effectively cured it. And then you can identify that subset, that population of patients, and say, we know you're a polyp former. We need to watch you more closely. We'll do colonoscopies more frequently. And that's how we can prevent it.
I feel like somebody who was very well trained. I went to Baylor College of Medicine, of course. I feel like that wasn't the standard conventional wisdom when I trained, that the polyp became cancer. There were polyps, and then there were villus polyps, and then there was, there was this range.
Yeah.
But has kind of the thinking changed now? Like most polyps are bad?
No, you just didn't listen in medical school.
He was too busy.
You were thinking about all those testicular exams you were going to do. And
That's right. When it came to the colon, I was like,
that stuff,
just poop it out, buddy.
No, it's how I describe it is it's actually a spectrum, right? And it's you start at the very benign end of the spectrum is there polyps, what we call hyperplastic polyps, which are basically like ditzels, little warts on the inside of the lining of the colon. And then the progression goes tubular adenoma, villus adenoma, tubule villus adenoma, and then dysplasia, which then becomes cancer. So it's really a sort of a spectrum from less aggressive to more aggressive.
Well, your work in colon cancer screening and support of that is amazing. How do people become patients of yours, and what's your website?
For sure. So you can go to tcrscolondocs.com. You can also just do a search for Texas Colon Rectal Surgical Specialists. Is that right? Yeah, Texas Colon Rectal Specialists. We're also a subsidiary of Texas Oncology, so if you go to the Texas Oncology website, you can find us through there. That's probably the easiest way, those three methods.
Well, thanks for joining us today.
It's my pleasure. Thank you for having me.